All right, good afternoon, everyone. Welcome to this afternoon's workshop. We're really excited to run this workshop. It's really the first of its kind. And so we've got Dr. Mulligan here with us and also Lilian Fellner to run through a hands-on anatomical teaching experience, really unlike anything else that's been done before. So Ia is going to provide a further introduction to her background and also to Lilian's background. So we'll start off with an introduction and then get into the hands-on part of the day, and then we'll finish off with some insights and teachings from Ia herself. So I'll hand over to Ia.
Great. Hi, everyone. So what is going to happen is I'm going to warble on for about 10 minutes at the beginning to give you time to get your gear together. So what you need to do is find the things we sent you and put them all very close to where you are, because once Lilian starts going through building the pelvic floor, if you stop, you're going to get left behind. So try and get everything together, all your pieces that you've made, and put them nearby. And while you're doing that, I'm just going to chat. So I want to start by acknowledging that I'm calling in from Kaurna land, right on the Chilbrookie Dreaming, south of Adelaide, and pay my respects to the Kaurna elders, especially Chilbrookie, and all the Kaurna elders, past, present, and emerging. I've also got some other people that I want to acknowledge. Sarah McNeil is a fabulous Australian doctor who lives and works in California, and she's the one who really worked up using fruit as a teaching model for novice surgeons, and that led to the dragon fruit workshop that I did at a PVOGS conference on the Gold Coast, where we had 120 PVOGS doing uterine evacuation on fruit. Also, Deborah Myers, who I've never met, but was kind enough to share her workbook with me. So she and her team have, prior to COVID, been flying to Singapore and meeting Australian doctors there at something called the Laparoscopic Complications Workshop, and doing clay modeling anatomy work. And hearing about that was what gave me the idea that actually that might be very helpful and useful. I want to acknowledge Nicola Spurrier, our Chief Medical Officer in South Australia. Who knew that epidemiologists and public health physicians were going to become new public heroes? But she's been persistently telling me that COVID is here to stay, and I need to find teaching methods where I'm not going to contaminate you. And so this is what we've come up with. And of course, Professor Helen O'Connell, who published the first peer-reviewed articles on clitoral anatomy last century. And she's a world-famous expert who lives in Melbourne. No one in Australia's ever heard of her, of course. And I want to thank PVOGS, because they really took up this idea and ran with it, and gave us Madeline Rock, who's done an enormous amount of work on the nuts and bolts and actually getting us organised. My name's Ia Mulligan, and I'm retired now after a long, happy career as a sexual health care provider and very multidisciplinary background. And I want to talk to you about Lilian Fellner, who's a real find for me. So Lilian's a medical student who's enrolled in the Doctor of Medicine course at Flinders University. She was also an accomplished artist and sculptor before she got to medical school, and she's brought those skills and her knowledge of anatomy into creating this workshop. She's currently conducting research, interviewing clinicians about the pelvic anatomy that's actually required for clinical practice. And she won a teaching award in 2020 for the creation of a teaching module where students would make pelvic organs out of plasticine. She's passionate about medical education and particularly making anatomy knowledge relevant and accessible. So she's the one for us. Oh, I've only taken up 5 minutes and I was going to warble on for ages. So what do I want you to get out of this? I guess the reason why this workshop has been designed this way is to really try and give you a 3D grasp of what's going on in the pelvis and the perineum. I really got interested in this because I spent a lot of time when I was working teaching novice surgeons how to do low-risk surgery, that is dilation and curettage, suction evacuation, inserting Mirena's procedural work. And in order to do that, you really need to have a three-dimensional picture in your mind's eye somehow of what is in there, because these are blind procedures. So you're reaching in where you can't see. And even if you have an ultrasound going continuously on the abdomen, that gives you some vision of where your tools are, but the screen's off over here. So I'm really hoping that this particular teaching method is going to give you a better grasp of what you can feel during pelvic examination and where things are that might be important if you were ever planning to conduct procedures in the pelvis. And also to introduce you to the clitoris. This new scientific discovery, which, you know, many people already knew existed, but has not found its way into medical teaching texts yet, is being propagated around the world outside of medical schools these days. And we've produced this anatomically correct model to assist with teaching with a lot of help from Helen O'Connell. So the one you have is a prototype, and it's made out of injection molded rubber and silicone. And it's not as soft as the real thing. And that's why, even though all these structures are really quite superficial, it's quite difficult to palpate them because they're surrounded by other tissues that have a very similar texture and elasticity. And the other thing to know about this particular clitoris model is that this is an engorged clitoris. So this would be in the aroused or excited state. It doesn't change shape a lot, and that's why I've avoided using the term erectile tissue, because it gives everyone the impression that something moves, and actually what happens is these bulbs enlarge and swell. So in a flaccid state, they're a bit more like a spatula. But as far as the amount of room that this takes up in the perineum, that's about right. This is life size and designed to go with the PVC model pelvis. So we'll be doing that later on. I do just have one other model that somebody else made that I really like that I'm going to show you. This is a block of see-through silicone which has got genitalia molded into the outside of it, and then a very brightly coloured clitoris inside of it, which sort of blows through and kind of gives you a bit of an impression about where things are in relation to the anus, the vulval opening, and the clitoral hood. So that was just sort of a sneak preview. But what we're really going to do is Lilian is going to spend about 45 minutes now taking you through building a pelvic floor. And then I'm going to talk to you about pelvic examination and what you can feel on the other side of the pelvic floor when you're examining, and go on to build a perineum. And then I'm going to end up with some physiology and clinical correlation at the end. So okay. I'm just about ready to hand over to Lilian. Are you ready for us, Lilian?
Yes, thank you for that introduction, Ia. Can you hear me okay, everyone?
Loud and clear.
Good. So I'm going to explain what's going on with my cameras firstly. So this, I have my hands in here, hello. And then here I have my face over here, which I'm just going to turn off in a minute, but I just wanted to say hello to all of you so that you could see my face first. And I'm going to ask you all to turn your cameras on if you can. And I've just put us on gallery view. Is that possible to do, Maddie?
Yep, it's physically possible. Yep.
All right, great. So if you can hold up your pelvises. Yep. Welcome everyone. I can see my screen filling up a little bit. I can see 9 people at the moment. All right. Are we getting? I'm sure we have a second page of people. I can only see 9 at the moment. Oh no, we're getting more. Oh, one person didn't get a pelvis. So if you have a pelvis and the plasticine, do you have a workspace with your pieces of plasticine prepared? Can you show me that if you have it? Yeah. Yeah, beautiful. Beautiful. So I've got a couple of things here as well. I've got a few tools. So I've got a pair of forceps and my preferred cutting tool. Scissors are great. And it's fine if you've got dodgy internet, Natalie. Some people are still waiting. You'll have to do it afterwards. I think we can probably get a recording so that you can follow along afterwards. And then the other material is here. I've got a piece of nerve with 2 bits plasticine on the end, or yarn. So I can see that everybody's, or many people in our workshop are ready to go. So that's really exciting. I'm just going to turn my face off so that you can just see my hands. And I want to talk you through, now that we've established that we have a majority of people with the materials and you're all ready to go. I'm just going to clear all of this out of the way and just talk through some of the important landmarks in the pelvis. But first, I do want to mention and reiterate what Ia was saying, that I really want you to get a good 3D understanding of the structures that make up the pelvic floor throughout this workshop. And for me, the most important things that I understood when I was learning how to make this was that there are multiple layers, what's deep to what, and that the perineum and pelvic floor is very curved, even though it looks flat on textbook diagrams. So I wanted to say also, if you have any questions or you're confused about any of the structures as we go along, could you please put it in the chat? And then Maddie, could you alert me to any questions as they come up, please? No. Thank you. All right, so let's get started. Let's talk about some of the landmarks of the pelvis. So you can hold your pelvis and identify these structures along with me. So firstly, the pelvis is made up of 3 bones. You've got the left hip bone, the right hip bone, and the sacrum with the little coccyx at the bottom. So when I say left and right, I'm referring to the patient's left and right, or the woman's left and right. So this is her left side. The hip bone itself is made up of 3 separate parts that fuse during childhood. So those are the ilium, the pubis, and the ischium. And we'll just talk about a couple of important landmarks on those. So here with the ilium, you've got the iliac crest, then anterior superior iliac spine, anterior inferior iliac spine coming across. This is the superior pubic rami. This is the pubic symphysis, inferior pubic rami. And then it transitions over to ischium about halfway down that inferior pubic rami, which means that we start getting names of the ischium down here. So we have ischial tuberosity and ischial spine. A really good way to conceptualize those 3 different parts of the pelvis is that they all meet at the acetabulum, and it kind of looks like a pie chart. So you've got a nice slice of ilium, a slice of pubis, and a slice of ischium down there. And then if we go posterior, I can see the sacrum, which is made up of fused vertebrae, and these are the sacral foramina, and the sacral plexus comes through there. And then here we've got the coccyx at the bottom. And this is the obturator foramen, which will be relevant in a few minutes' time. So how do we talk about this space as well? So there's a couple of important definitions here, which is firstly, the pelvic inlet. So that's defined by the ilium laterally, pubis anteriorly, and sacrum posterior. So it's this ring. It's very obvious what would be the pelvic inlet. And then this space in here is called the true pelvis or the pelvic cavity. And then down here, we've got the pelvic outlet. So baby's head needs to be able to fit through here, very important. And those landmarks are ischial tuberosities, pubis, and coccyx. So that forms a diamond shape. And then we actually define or split this into two different parts. So there's the perineal or urogenital triangle on the anterior side, and then posteriorly you've got the anal triangle. And well, the anus comes out of the anal triangle, and the urogenital triangle, the vagina and the urethra come out, and the clitoris sits in that space. So what's above the pelvic inlet? That would be the abdominal cavity. And also this area defined by the ilium is also called the false pelvis. So we've got false pelvis, true pelvis, or pelvic cavity and abdominal cavity. Okay, so that's landmarks. This is the structure we're going to be working around in the next 30 minutes or so. So I'm just going to get my first template around, which has a couple of important ligaments and muscles, and these form the posterolateral sides of our pelvic cavity. And I want to talk a little bit about how to use the template. So obviously you've got a piece, it's fairly intuitive that you would fit on there. It's also numbered in the order that we're going to be putting it on. So number 1, sacrospinous, and so on. And I've added an extra feature, which is the weight, which unfortunately wasn't sent out with your copies. So if you had trouble with the thickness, then you can just put in the chat what was the weight of that structure, and then you can maybe get a pair of scales and it will help you get the right thickness, or how many millimeters thick is that. That could help. And then also you can also see that it's got the attachments marked on there. Okay, so let's start with our first structure. This is the sacrospinous ligament. It's important for stability as it runs between the sacrum and the hip bone. It runs between, and as its name suggests, the sacrum and something spinous, which in this case would be the ischial spine. So you can easily translate this across. So we've got sacrum and coccyx on one side, that's the slightly wider side. And then it runs across, and it should just fit the right length across to the ischial spine. So for plasticine reasons, I've given that a little bit of overlap. So that's going to be a really strong, important ligament for us. It forms the boundaries of some important structures, and you can also anchor things to it during surgeries. And when I say things, I mean uterus during a vaginal prolapse repair. So that's the sacrospinous ligament. I'll let you have a look from the front as well. So you can already see that it's starting to form a bowl in there. All right. So our second important ligament, also important for the stability between hip bone and sacrum, is our sacrotuberous ligament. And that runs from the sacrum to something tuberosity, which is the ischial tuberosity. It's handy how the names actually make sense sometimes. So you can see here, you've got the sacral attachment marked and then the ischial tuberosity attachment. So just make that lay that on, and you'll know you've done it right if you have a big space up here. I might just use my forceps to indicate. Big space up here, and then a littler space down here. And those two spaces have anatomical names as well as that space over there. So this is the greater sciatic foramen, this one. And this little one, well, it's smaller, it's the lesser sciatic foramen. So those have nerves running through them, vessels running through them, and muscles. And so they are also important landmark structures to understand. So from the inside, there you can see my hand through that greater and lesser sciatic foramen. Yeah, so I can see a couple of people that have got that on there already, which is great. So next, let's add 2 external rotators of the hip that originate in this pelvic cavity. So this one that looks a bit like a fork is the piriformis muscle. So the reason it looks a bit like a fork is just because I've made sure that we're not going to have overlaps with our sacral foramen, because it wouldn't make much sense to have a muscle over the top of a hole that a nerve is supposed to come out of. So how does this fit in our pelvis? Well, we're going to go through the greater sciatic foramen, and then imagine it going out to the greater trochanter of the femur. So this, my fist, is a pretend femur, as we don't have a femur in our model. So part of the ball and socket joint, the greater trochanter is this bit out here. So imagine a muscle that extends from in there to out there. I'm going to take the narrow bit and I'm going to thread it through the greater sciatic foramen. There you go. So I'm just going to show you from behind. I've just threaded that straight through. Okay. So sometimes that can be a bit tricky to see. So I'm just going to do that action one more time. So here I've got the narrow bit. That's going to go to our greater trochanter of the femur. And here's the wide bit that's attaching to our sacrum. And then I'm threading it through the greater sciatic foramen. And then I'm going to give it a really good press on the sacrum side. And you can already see that a wall is forming in there. So an interesting thing about the piriformis is that the sciatic nerve can either run deep to, superficial to, or through the piriformis, which is a really fun little anatomical variation fact that I enjoy, because it reminds us that we're all a little different. So now we've got this kind of flappy bit out here, since we don't have a pelvis. Sorry, we do have a pelvis, but we don't have a femur. So I'm going to do something extremely unanatomically correct, and I'm going to tuck that in to the acetabulum for safekeeping. So the muscle certainly does not run in this way. This tendinous attachment goes out to the trochanter, but we don't have one, so this is how we're doing it. All right, this is what we're going to make work. All right, so now we've got this obturator internus muscle. Now I mentioned the word obturator before, didn't I? That was in relation to obturator foramen. So funnily enough, the obturator internus muscle sits just internal to the obturator foramen. So this one looks a bit tadpole-y. So say this tadpole is swimming up, its tail is down. So have it oriented that way. And this is the tendinous attachment of our muscle. And this is the muscle belly. And this also goes out to the greater trochanter of the femur, which is why they're external rotators of the hip. So this one passes through the lesser sciatic foramen. We've just done this trick, except with a slightly larger muscle. Can you see that? How the muscle belly of obturator internus is sitting on the inside there. And then if you look through obturator foramen, all I can see is red. That's all obturator internus muscle. All right. And then we've got this tendinous bit sticking out. So in a person, it's usually about 90 degrees. So that's what we've got here. So if I look from below, I can see this 90 degrees forming. And then this tendinous piece, that would also head out to greater trochanter. I'm tucking it into the acetabulum for safekeeping. Okay, so we're starting to see the walls forming. That's part one. How are you going? Can you hold up your models? Let's have a look. Yeah. I can see Simran's looks good. What else can I see? Can I see anyone else? Israel's looked good before it came down. Ia's looks good, of course. She's only done it several times. All right. So if you've got any questions, just reminding you, you can put them in the chat. Oh, so I'm just getting round two. These pieces are going to form what we call the pelvic diaphragm, and we've also got anus there, but I'll just put that aside for later. So I just want to talk to you a bit about the pelvic diaphragm, but first I'm going to backtrack slightly, and we're going to put in the pudendal nerve. So I'm just going to actually tuck that away, and we're going to talk about this little kiddo here. So I've got a blob on one end and a blob on the other end, so that'll just help us with structural creation. But let's just talk about the pudendal nerve for a second. So we've selected this as the one and only nerve we're putting in this model because it is the nerve that innervates the perineal region. So there are several branches that come off the pudendal nerve, which we won't be making, but understand we'll be talking through how the pudendal nerve gets to the perineal region. And the branches that come off include the perineal nerve and the dorsal nerve of the clitoris. So their origin, the origin of the pudendal nerve on the other side is S2 to S4, and so it comes off the sacral plexus. But again, we won't be making that part. We'll only be doing this middle segment. Functionally, it's both motor and sensory. So it is involved both in movements and in sensation. Now, how does it fit? We've got sacral plexus coming down here. So that's a good place to start, right? So I've got mine about halfway down the piriformis. And my piriformis is actually a bit wide, so I need to make a bit of a hole there. All right. Because this nerve doesn't just head straight in there, because, you know, that would kind of make sense. You'd just be like, oh, yeah, I can see. There's the sacrum. There's the perineal region. Well, and just go straight through, right? This nerve, it goes in a very safe, protected track. So let's poke that through to the outside. Oh. All right, so this is where my forceps come in handy. So I've just poked that through. Whoop. So that's just come through the greater sciatic foramen. So is your nerve between the piriformis muscle and the sacrospinous ligament currently? Yes, we have somebody doing that, right? And then it heads in through the lesser sciatic foramen. Whoop. Oh, now it's more like in the right space. And then we're coming back to the inside here. So I can see this nerve is tucked away behind. So in a woman, they actually have a slightly different track, men and women, the pudendal nerve. So in a woman, it sits right at the base, at the most inferior border of obturator internus. So I'm just going to show that to you nice and clearly there. So that's where this pudendal nerve sits. And I'm just going to anchor it up here at the pubic symphysis just to keep it out of the way. But just imagine this yellow line, imagine that branching out innervating all of these important structures in the perineal region. Okay, so that's the one nerve that we're going to put in today. Now let's add our pelvic diaphragm. So what's the function of the pelvic diaphragm? Well, it's support for the pelvic viscera. So that's fancy words for organs sit in there, don't fall out because sling. So there's a muscle sling in there that makes sure that our organs don't go anywhere. So the important organs that's sitting in the pelvic cavity are most anteriorly the bladder, then the vagina and uterus, which sits over the top of the bladder, and then, sorry, and then posteriorly you have the anus, rectum coming up, and then you've got all of the guts and things. So all of those organs are the ones that are being supported by that pelvic diaphragm. And when you increase your abdominal pressure, such as when I just sneezed, you need to also make sure that no pee falls out of you, no poo falls out of you, and no organs fall out of you. So it's doing all of those functions as well. So that is aiding in micturition, or not, continence, urinary and fecal continence. And when there is dysfunction of the pelvic diaphragm, pelvic floor, then you would get prolapse, which is when the organs do start to fall out. All right, so now that we've talked a little bit about function, what are the muscles that make up this pelvic diaphragm that I keep talking about? Well, there are two muscles, and you may wonder why we've got so many parts here. So those two muscles are the coccygeus and the levator ani. And then the levator ani is made up of three muscles. And the reason that we've done this separately is because they actually have, the muscle fibers running in different directions. And it's actually quite conceptually, I find easier to think about the pelvic floor as a curved structure when you've got all of these pieces that then fit together. So let's put in the location of the coccygeus. So this is also called the ischio-coccygeus, and funnily enough, it runs from the ischium to the coccyx. So let's start with the coccyx side. So I'm just going to thread that through, and I've got this piece. I'll just press down at the coccyx, and then over here at the ischium, so that's the ischial spine. You'll find it actually runs in exactly the same track as the sacrospinous ligament. And so that means that the layers I've got here, I've got sacrospinous, and then immediately deep to that, I've got this coccygeus muscle. Okay, so levator ani part 1 is iliococcygeus. And you know how I keep saying that the names are really logical? Well, this is the one time where it's not. So it does kind of run from the ilium to the coccyx, iliococcygeus. However, and this is something that was very confusing from textbooks, it actually attaches about halfway up obturator internus. Sorry, can't see that. Can you see that? Halfway up obturator internus at a line called the tendinous arch in English. So there's a fascia that runs over the obturator muscle. Then that fascia makes it continuous to the ilium, which is why I assume that some anatomist at some point decided to call this iliococcygeus. Otherwise, it would be obturator coccygeus, maybe. So are your muscles about halfway up your obturator internus? Yep, I see nods. Okay, so I'm just going to give that, so I'm just going to attach that there to the coccyx. And something that I've been assuming throughout that you understand is that all of these muscles and ligaments have a mirror image on the other side. So that's why they're forming a bowl shape. We're doing a half, partly for time and partly for access. All right, so now I have this iliococcygeus muscle. I have it at the midline with attaching to the coccyx, and then I've got this border along with the coccygeus muscle and then attaching halfway up, obturator internus. Are we all happy? Yes, I see thumbs up. All right, let's move on to part 2 of Vata ani. Now I'm just going to take puboanalis, also called puborectalis, and I'm going to take pubococcygeus, and I'm just going to attach one to the other, because we're going to put these 2 bits in together. So the puborectalis muscle sits superficial, that is closer to the surface, and also you can describe it as inferior to pubococcygeus. And what's this sort of scoopy out bit that's going on here? That's a bit weird. Well, that's going to be our urogenital hiatus. And on my template, and this is a bit cheeky because I've done something different to you, I've got a sort of half circle cut out, which is the anal hiatus, but I'm not putting mine in yet because I want to make sure that it's in the anal triangle when I put it in. So I'm going to put in this muscle piece first, and then I'm going to add the anal hiatus in afterwards. So now that we've got this sort of complex of the pubococcygeus and then puborectalis inferiorly, which doesn't completely cover pubococcygeus, now I've got this complex, I'm going to put it in. So it fits attaching pubo to the pubis. All right, so I've got that attaching to the pubis. There's a little bit of overlap with the brown one, with the iliococcygeus, and then it should be forming a midline. How are you going? Anyone want to show me your pelvic floor? Hold it up to the camera if you've got it. There's mine. And I'll show you mine from below now, while I give you a little bit of time to catch up, because everybody's looking down and concentrating on something or other. That's what it looks like from below. So let's just talk through what we've got here so far. So we've got puboanalis or puborectalis, and then pubococcygeus peeking through. So I can see a little bit of my pubococcygeus, and then here a large bulk of the muscle being taken up is iliococcygeus. Now I think that my pelvic diaphragm doesn't have enough of a curve yet, so I'm just going to give it a bit of a massage to make it more curved. So I'm going to make sure that it's fixed really firmly to that obturator internus muscle and the pubis, and then I'm going to give it a good squish. And I want to get this curve. Oh, you can see I want to get this curve up to about the line formed by the ischial tuberosities. All right, I'll move on once the first person shows me their on-track pelvic floor. Because otherwise I'm going to assume that you're not quite ready yet. Yes, we have a Simran who is showing us a good-looking pelvic floor. Fantastic. All right, I'm happy to move on if you are. And I also want you to note the location of our pudendal nerve. So I can see it there. Hope you can too. And we're also going to have a bit of a space developing, and that's absolutely fine because lots of vessels and nerves run through there with a good padding of the body's bubble wrap, which is adipose tissue. Okay. So now we've got an external anal sphincter and anococcygeal ligament. I'm just going to run my anococcygeal ligament. Oh, actually, I'm going to add an anus hole, anus hiatus. So there we go. I'm using this to identify my anal triangle, and I'm going to give it a bit of a pinch. There we go. I'm going to put my anus there. And then I'm going to run the anococcygeal ligament up to where I've made that anal hiatus. And now I do have an anus here that's ready to go, but it's a big chunky piece. So this, my anus, my plasticine anus, is around just under 4 centimeters. So that's a little on the larger side, but you'll find an external anal sphincter runs from about 2.5 to 4 centimeters in a normal person. So we're actually talking, this is a good size for what we're talking, but because of its size, it's going to fall off. Therefore, I'm going to leave it until a little later. All right. So part 3, and we're coming up to Iya's area of expertise soon, but I'll just talk you through some of the structures that we have. Here. Firstly, you might be wondering what's going on with this like 3-piece labia minora. So the answer to that is the labia minora is a bit of a wedge shape. So if you just put the roll along one side, then you instantly have something that's, let me see, about 6 millimeters on this side. And then I have about 2 millimeters on this side, which will give us the right shape later. And Iya will be talking you through the placement of labia minora. There you go. So I just wanted that complex to go together for you. I'm just going to put that back over there. All right. The next thing is all of these structures that are going to go here, they are going to fit in our urogenital triangle, perineal region. Same thing, 2 names, which is like a few things in anatomy. Now, we have some muscles here on the perineal membrane, which is a very thin structure. And the structure I have here, even though it's only a millimeter thick, is too thick to be realistic. But we need it for some kind of structural integrity. But the muscles we have here are muscles that are important for continence. So sphincter urethrovaginalis goes around the vagina and urethra, which would be located around here, the urethra, because we have compressor urethrae coming in, and then vagina would be fitting down here. And then we have the deep transverse perineal muscle. The other important structure that I want to talk about is the perineal body. And we had a choice. We could have, and I have this in the template, a separate color, but I've decided not to do that because the perineal body, the concept of the perineal body is that it's a fibromuscular mass that is the join of many structures in the perineal region. So we're just going to fit this perineal membrane onto our pelvic floor model, and then I'm going to hand over to Iya after that. So what we have here, this complex that you will have made already, that's the deep side of the perineal membrane. And that means that the orientation is going to be like this. Can you see that? So the other important thing to understand is that it's not flat like this. This is what it looks like in a textbook, but really we're talking a big curve here. And a really good way to find out how curved it is to take this 3D printed clitoris, which is based off MRI scans, which means we know it's accurate, and then use that to define the curve. So if you press it to the back of that bulb, these bulbs of the vestibule, you'll be instantly forced to get a curve. So now you have a concept of how curved this perineal membrane needs to be. Let's put it in. Okay, and I can see that my obturator internus is creeping into a space where it shouldn't necessarily be. There is a groove running along the inside or the inner surface of the inferior rami of the pubis, and that needs to be clear for the crus of our clitoris, which is why I've just cleared it out for plasticine. So you may need to do that as well, since that's a template issue. Let's fit in the perineal membrane. I'm going to get this nerve. I'm going to get this nerve coming up here on the outside because I want it to be on the outer side of the perineal membrane. And then I'm going to fit. This is pressing on the inner side, on the deep side of that inferior pubic rami, coming down to the ischial tuberosity, up to the pubic tubercle. And that big cut in the middle, we need that space. That's lining up with our urogenital hiatus going through the levator ani muscle. There we go. There's mine. And mine's got a big curve built into it. That's what you need. I'm going to check that with the clitoris. I'm happy with that amount of curve. Is yours that curved? So I'm going to put a fist in here, and I'm hoping that you have plasticine lining most of your pelvic cavity. You've got a big curve down there. This is where the organs are sitting. And then you've got a bit of a space here. And that's where that bubble wrap of the body is sitting with the important structures, very protected, lying through there. And then you've got perineal membrane and you've got pelvic diaphragm, which in this part is the levator ani muscle. So I hope that gives you a really clear understanding of the layers involved in the pelvic floor. Once you've made it, it should be a lot simpler in your mind, being able to picture when you go through the vagina, what you will be palpating. All right, now I'm going to hand over to Ia. And we can't quite hear you yet, Ia, so try unmuting yourself.
Sorry about that.
No worries.
Okay. And so I'm just going to tip my computer down so that the camera is pointed at the model. And I've got one here. When I started thinking about this, I was using a slightly larger pelvis, and I went out shopping and bought some tomatoes in this little egg carton tupper. And I thought, gee, that's about the size and shape of the true pelvis, if I squashed in the back of it a little bit to take into account the sacrum there. And I've made a little hole in the bottom, which is where an examining finger might go. And I'm just going to use that to demonstrate. So the thing I want you to understand about vaginal examination is it's a pretty crowded space. There's a lot in there, and all these things move and change size and shape. So one fixed structure is the proximal urethra, which is actually an organ. it's quite 3 centimeters across. It's quite a substantial organ, and it lives in the front here, right behind the pubic bone. And if you're lucky or sensible, and the woman that you're examining has emptied her bladder, the bladder doesn't take up much room at all. But of course, you know, if there's a couple of 100 mils in the bladder, it does take up quite a bit of room and pushes everything else back. Then behind that, I've managed to find a balloon that's kind of a bit uterus size and shaped, and even has a little bit of a cervix. So that's behind there. And then at the back is the rectum. And just depending what's going on, I use this stocking to be a model rectum, and I've put some limes in it just to demonstrate how much space is taken up if there's a bit of fecal material in there. And you can see that just depending on the time of day and whether the person you're examining is constipated, and whether there's urine in the bladder, all these things that move around a lot. But they're very close to each other and very thin walled. So the vagina would be pressed between the urethra and the rectum there. And the walls are very thin, so you can even work this out examining yourself if you put on a glove and get some lubricant. If you put your thumb in either your vagina or your rectum and your finger on your coccyx, you can grab the whole mechanism of fecal continence between your fingers. And that makes you realize just how substantial an organ the anal sphincter is in the anal canal. And I'm just going to talk for a moment about where the nerve receptors are in the anal canal, and what you need to do if you're putting a suppository into the rectum. So the anal canal is quite long. Even as it dilates, it gets a bit shorter. And if you put in a suppository, I've just made a plasticine one here, you really have to push it and chase it with your finger for quite a long way. You can feel the anal sphincter squeezing on your finger. It has to go past that, and then it just disappears off into the rectum and melts, and that's a very good area for the absorption of medications. We used to use Indocid suppositories a lot in the emergency department because we were trying to use every other form of pain relief that wasn't an opiate. And certainly for post-op pain relief after gynecological procedures, I've put in many of these, and it's made me realize just how many fit young women are constipated. The other thing that it's really important to realize is the sensory nerve endings are all in that canal. And then once you get past the dentate line and up into the rectum, there are not many sensory nerve endings in there at all. So a suppository or a sex toy can disappear up in there and kind of be very hard to get back. And emergency departments used to have a lot of sniggering in the tea room when someone came in that had lost something into their rectum. And it was always assumed by the staff that this was some sort of sexual activity that had just sort of got a bit out of hand. But looking back, I think that they were probably assaults, really, that you know, the Bucks party where everyone gets drunk and turns on one of them. And anyway, we won't go into that. So when you put your finger through the pelvic floor, either into the rectum or into the vagina, as you're running your finger back from the external opening of the urethra, you can run it right along the urethra. And if you do this yourself, you'll understand just how many nerve endings are in there. And then the next thing you come to is the posterior urethra. the bladder may be quite insubstantial. The cervix is the next thing that you hit. And if the uterus is anteverted, if you put your finger under the cervix and push up, you may even see the
you're drifting upwards. Can you make it so we can see?
Yep.
Thanks.
Is that better?
Yeah. Thank you.
Can push on the cervix and the fundus of the uterus will bounce up and push on the back of the abdominal wall, and you can see a little bump there, particularly if there's a pregnancy. And I found this lemon that even has a bit of a little cervix. That's about the size of maybe a 9.5-week pregnant uterus. So you can kind of picture if that's there, and if there's a bladder there, it's pushed back. Or if it's retroverted, it's pushed back. And then if you push up on the bottom of it, it just goes up that way and you can't feel anything from the front. But if you're trying to estimate how far along in gestation a uterus is, you want to try and get your finger under the cervix and your other fingers on the abdominal wall, and you can bounce it between the two sets of fingers. So those are just my comments on examination. And now I'm going to go back to building the perineum, which mine is not as beautiful as Lilian's, I'm sorry to say. I didn't quite make my perineal membrane capacious enough, but hopefully I'm more or less up to the same place that you are. I don't want you to forget about those muscles that you've buried that are on the back there, because they're quite important muscles. They're part of the orgasm reflex. They're part of continence. They all attach together at the perineal body. And then there's just more and more. So if you pick up your superficial transverse perineal muscle and put it across here along the back edge, that's part of it. Goes sort of from one sitter downer point to the next. That might actually help me keep my perineum tinted properly. And the next thing I'm going to get you to do is dress your clitoris with its muscles. So we've got the clitoris here, and starting with the ischiocavernosus muscles, they're covering the crura. So just get them to stick on there. I made a pair of them. You don't have to have a pair. And they're very thin little muscles, but they're strong. And like all muscles, they get stronger with exercise. And this is the whole point of perineal exercises. And my obstetrician friends tell me that there are certain people like cyclists and Pilates teachers who always have very strong perineal muscles. And if they haven't learned to relax them, that can cause some trouble in childbirth. Now, Lilian has made these bulbospongiosus muscles, and I really didn't get why she'd made them this shape until I realized that she's a genius. But you can see that the bulbs of the clitoris are quite lobular. And if you take this little muscle and put it together like that, so it's pleated, you can make a dome. So the long flat edge goes to the midline, and you can clothe your bulbs like that. So here we go. Here is the clitoris invested with its muscles. And in most anatomy textbooks and perineal diagrams, this is all you see is the musculature. There's a little dot there where the glans is. So we've got glans, body, crus, Two of them are crura and bulbs. And the crura tuck right in under the edge of the pubic bone. So they're very protected. And I didn't get you to make one of these, but I'm just going to put this in so you can see where it is. There's a suspensory ligament, quite a strong little one, just behind here, holding the body of the clitoris onto the symphysis pubis. There's also a superficial suspensory ligament that just sort of fans out into the tissues of the mons. And you probably wouldn't, most anatomists wouldn't even distinguish it, but Helen O'Connell has published on this topic. So you can see here that the perineal membrane is just about disappearing, and in fact, in places it's pretty hard to even know where it is on dissection. And the next organ that I want you to put in place is the urethra. So the distal urethra is a little bit narrower, but it's got a lot of tissue that engorges. It's quite spongy. It's got quite a thick wall. Then there's the sphincter urethrae, and then there's the proximal urethra, which, as I showed you before, is actually going inside the pelvis. So the distal opening comes out just between the bulbs of the clitoris, and it stands forward a bit. And that little green ring is going to join in with those other little green muscles that you disappeared behind the perineal membrane. And there you have the deeper structures. And Lilian's model was better because it was a bit more tinted, but here we go. And there's the rectum, very close there. So all these midline structures are in a row, and that's why it's easy to find things. Now, the last thing I'm going to put together, which I didn't get you to make one, is I've got a bit of stocking here to simulate a vagina, and I'm just passing that in. So the thing to understand about the vagina is, at rest, it's orientated that way. It's very tempted to think, because all the labia are running this way, that the vagina is running that way as well. It's not. It's like this. And it's a very elastic walled organ. And so it kind of just crumples up. It's very rugose. And that's part of the secret of its elasticity. Oops, I've managed to lose my urethra there. So you can see that the first part of the vagina is surrounded by tissue that engorges. They're the bulbs of the clitoris. There's the external part of the urethra. And then the last protective layer that I really want you to understand and visualize is I've made out of sheepskin 2 labia majora and a mons, not because I want to give you the impression that these organs have got hair on top of them, but so that you understand just how much buffering and protection they supply. Now, I've realised I've left some organs behind. I've left the labia minora behind, sorry. I've got ahead of myself here. So there's your labia minora, okay, and the clitoral hood. So I'm not sure, I think I'm going to put that way up. So the clitoral hood often covers the glands of the clitoris completely, And then the labia minora are extremely variable. So quite often in a diagram, you'll only see the attachment line, and it doesn't exactly correspond with the bulbs of the clitoris underneath. And they're pretty midline. And, you know, when you're standing up or sitting down or ordinarily in life, they're often all folded together like that. The body of the clitoris disappears up under the mons. So what you end up with is a very protected organ. There's a lot of buffering and padding here. There's a lot of buffering and padding there. There's a hood. There are the labia minora, which are all crumpled up in ordinary everyday life. And I just want you to get the orientation right and understand that when you're standing up or sitting down or walking around, the glands of the clitoris is pretty much pointed towards the floor. And even though it stands out from the bony pelvis, it doesn't stand out from your body because there's all of this padding that's more superficial. So I think that's the end of my demo. And I think what I want to do now is talk to you about some more clinical issues. Let me just... Oh, Helen O'Connell says that midline sagittal sections are very problematic for teaching, but I am going to just show you this one because here's the clitoris. And of course, with the midline sagittal section, all you can see is the body and the glands. There's the distal urethra. Here's the proximal urethra. It's quite an organ, and the bladder is up really quite high. They're the vaginal walls, and in this case, there's quite a bit of something in the rectum. But all of these organs move around a lot. And also you can see just how substantial the anal sphincters really are down here, and why if you're putting a suppository in, you actually have to chase that suppository quite a long way before it disappears into the rectum. So how are you all going? Are you feeling like you've got a model that tells you something? Oh, did I forget to deal with the dorsal clitoral nerve? This is the next iteration of the clitoris model will have the dorsal clitoral nerves imprinted onto it. And this is a cadaver dissection that Helen O'Connell has kindly lent us. And I just wanted to give you these two different views of a clitoris and what it looks like, just because it's a three-dimensional structure. There's a lot of anatomical variation, and there's a lot of different ways of looking at it. And I'm just, in the following slides, I'm going to show you as many different views as I can. Maddie, how long do I have from now?
About 20 minutes.
Oh, groovy. Okay. So one of the things that I wanted to talk to you about is where the sensory receptors actually are. Because if you think of arousal and orgasm as a cascade of reflexes, then it all starts with sensory receptors. We followed the track of where the afferent inputs are. There's a lot of processing going on in the brain, isn't there? And this is where issues like whether you want to be there or not are terribly important. And there's a lot of equipment in your brain to do with memory and fantasy, and you know that a whole orgasm can be generated while you're asleep during a dream. So you don't actually have to have any sensory inputs at all, but they certainly help. Then you have efferent outputs, and then you have your reflex. And I love this picture from Jasmine Abdul Qadir, because it's a montage of 81 MRI scans. So even though it's pretty blurry, it sort of gives you a view of the range of normal anatomy. So we've got the bladder up here. There's the posterior urethra. You can't even see the distal urethra because it's hidden behind the clitoris here, but it's coming out there. There's the clitoris. So there are a lot of nerve endings in the urethra. There are a lot of receptors in the glands and the body of the clitoris. There are a lot of receptors in the anal canal. There are a lot of receptors in the whole perineum. So there's a sort of a hammock of tissues, labia minora, labia majora, the introitus, that are all got a lot of nerve endings. There are not that many nerve endings in the rectum, and there are not that many nerve endings in the vagina. This has been made a bit bigger because the researchers put 60 mils of water into the vaginas just to make them seem a bit more substantial than they really are. And I'm going to talk a bit about the reflex cascades, just because this physiology is not really in medical textbooks, but lubrication is very important. And there are a lot of sources of lubrication. So you've got Skene's glands with little openings just either side of the external urethral meatus, kind of at about 7 o'clock and 5 o'clock. You've got Bartholin's glands, the openings much further back near the introitus, but the glands themselves, you'll often see a textbook picture that shows these glands like two little peas on either side, somewhere near the end of the cervical bulbs. But actually, there is no glandular tissue there. There's a tortuous passageway that crystal clear fluid passes up. But the actual glands, Helen O'Connell's done some very detailed, like microscopic dissections, and they cannot be found there. And if they're to be found at all, they're probably right back here and very deep, like maybe there and there, and tiny. Then the cervix is producing mucus, particularly at ovulation. The vaginal wall, there's exudation, there's transudation, there's a complex microbiome in the vagina. Those little lactobacilli are producing a matrix, a biofilm all the time. And the posterior urethra has got a lot of glandular tissue in it, and produces fluid that's got quite a lot of prostatic specific antigen in. And I don't know if you got the pre-reading materials, but if you've watched 100 Vaginas on SBS On Demand, there's an interview with a woman there who's talking about different kinds of orgasms and squirting during orgasm. And there's been this debate going on for several decades between anatomists and doctors and the rest of the generally sexually active public about whether female ejaculation exists. And I don't think that the physiological correlate has really been identified properly, but I've got my suspicions that possibly this is fluid coming from the posterior urethra. Different people have got different opinions. You can have an opinion. Maybe you'll do some research one day and find out what's really going on here. And when I was at medical school, none of these sources of lubrication got any acknowledgement at all, except to talk about discharge and, you know, whether this was a sign of some kind of pathology. or people talk about, you know, postmenopausal vaginal dryness, and there are a lot of therapeutic efforts to intervene and change the nature of lubrication. And, you know, some of these sources of lubrication are influenced quite a lot by your hormonal state. Lubricants are very important. There's a very big cultural thing in America of douching. So, you know, using something that's a bit similar to mouthwash to rinse out the vagina. It does nothing for your microbiome. I really don't recommend it. And of course, in surgery, we're forever using betadine or chlorhexidine and kind of swabbing out the vagina as if that's going to do something useful for infection control. And the fascinating thing about the work that's being done on the vaginal microbiome at the moment is there are a host of immune mechanisms going on in the vagina, including low pH and a number of virucidal compounds being produced and a local antibody production system going on. And actually, whether we're really adding anything by using antibacterial materials in there, I really am very doubtful myself, but it's a very brave surgeon or proceduralist who would say, oh, well, we don't actually need to clean out the vagina before we put in an IUD or perform a DNC. And the post-op infection rates are so low anyway, you'd need a really big cohort to prove a difference. So no one's actually got themselves together to do that research yet. But in the real world, this is what foreplay is all about. You know, these are all reflex responses to sexual engagement. And there seem to be a lot of heterosexuals who do not understand that even though penetration can be enjoyable, a lot of other things need to happen first, like lubrication. And the other thing I want to talk to you about is engorgement, because there's this kind of generalized belief system in our society that girls are very tactful and you can't tell anything about whether they're interested or aroused. And I found a very interesting pair of photographs that I'm going to show you of a woman's vulva before and after arousal. I found it on Wikipedia and Wikicommons. It very quickly got trolled by someone who said, well, who cares? And then it got taken down. I don't know if that was their censorship policy or whether it just got trolled too much. But clearly there's a lobby out there that's quite offended at the thought that women would have an independent sexual response. So here we have some kind woman has allowed this to be published anonymously so that we can learn something. Completely healthy labia majora. You can just see a little bit of the clitoral hood here. The anus is back there somewhere. And if you can picture where the clitoris is, it actually goes quite a long way out to the sides. It wouldn't completely be covered by the gusset of a pair of underwear. And then we have after arousal, and you can see how many different tissues engorge. So the labia majora are larger, the labia minora are larger, the clitoral hood is there. You can almost see the glands of the clitoris pushing up under it. And there's quite a bit of lubrication from, we don't know how many of those sources that I mentioned in the last slide. So it's all a matter of observation, in my humble opinion. The other thing that's not very well understood is just how much variation there is in external genitalia. And there's some really interesting research going on at the moment about how labia minora, majora, and the clitoral hood and the hymen are depicted in medical textbooks as contrasted with reality. And it sort of makes you wonder when a plastic surgeon or someone's doing cosmetic genital surgery is reshaping all of this, what the ideal or normal or perfect image is that they're trying to create, because the range of healthy is quite wide. And in passing, I'll just mention Betty Dodson to you if you've never heard of her. She's passed away now, but she's left behind a fabulous legacy of community education materials. She made her whole lifetime adult career out of teaching women who had never had an orgasm before how to orgasm, and she ran workshops and sold vibrators. And I told that if you have Netflix and you go into something called Goop Lab, that there's an interview between Gwyneth Paltrow and Betty Dodson talking. She talks about her work, and then she demonstrates. So a woman who's never had an orgasm before in her life comes to orgasm on the small screen in Goop Lab. And Betty Dodson wasn't the only one who was interested in trying to produce teaching materials that would actually educate women about their genitalia. And this is some fabulous work that's being done by Gemma Sharp. She was looking into before and after satisfaction studies with women who'd had labiaplasty. And one, she found it very hard to find any validated research tools. And two, she started talking to women about genital self-satisfaction and where did they get their ideas from about what their genitalia should look like, and why weren't they pleased with what they saw in the full-length mirror after they'd shaved all their pubic hair off. And they all told her that they'd made up their minds about whether they wanted to have genital surgery in primary school. And so she has responded by designing this completely G-rated TikTok video, which I don't think it's been released into the wild yet, but she used cupcakes to try and give young women an idea about the range of genital variation and why whatever they've got is perfectly all right, and really cutting parts of it off is not going to help anyone. And I think following on from that, I mean, it's interesting to consider what's actually lost by cutting bits of genitalia off. This is a pair of MRI recreations from Jasmine Abel Kadir. And one of them is a woman who's had female genital mutilation, and you can see just the glands of her clitoris has been removed. But as Helen O'Connell points out, I think there are something like 30,000 women in Australia who've immigrated here who had already had some form of genital cutting before they arrived, and they're certainly turning up on abortion lists and in labour wards, so you will see them. But the most common form of female genital mutilation that's going on in Australia at the moment is voluntary. Young women are paying gynecologists quite a bit of money to remove various parts of their genitalia. And APRA have become so concerned about this that they've actually put out a set of guidelines to sort of try and get medical practitioners to treat this as though it is actually a therapeutic intervention and they should get proper consent for it. The other thing I want to talk to you about is if you are the least bit approachable, people will ask you questions about their genitalia and about sex. And it's really good to be able to have some factual answers for them. And I'm really hoping that this workshop is going to give you more factual information to give answers with. But very common questions are, what's wrong with me? Is this normal? And, you know, sometimes there's nothing wrong. And the underlying problem is that everything that woman knows about anatomy she's learned from porn, which has all been altered and airbrushed, and all the labia minora have been removed. But sometimes there's a skin tag or something that you need to pay attention to. It's well worth doing a physical examination. Another question that's very common is, why does sex hurt me? And this is a very 21st century question. When I was growing up, it was expected that sex should hurt women, and that it was part of your job in life as a woman to just learn to put up with it. And this century, there are more young women who think that sex should be enjoyable, and if it's not, that maybe there's something wrong, and they'll come and ask. And this is where it's very important to do a careful physical examination, try and work out what organ the pain is coming from, where is it located. And in the past, it's been very tempting for doctors to say, oh, well, everything looks normal, it must be in your head. Go get some therapy. But I think with the discovery of endometriosis and the chlamydia epidemic and a few other things, it's sort of come to the medical profession's attention that there are some sources of pain and discomfort which actually we could help with. And it's very common for women to wonder if their experience is the same as everyone else's, or whether there's just something uniquely wrong with them. And I think that this is sort of part of the burden of femininity, is to think everything's your fault, or that you must have caused it, or that it serves you right. And that's why I was so glad to see 100 Vaginas come on the SBS, because it really is a fabulous community education tool where places women as the expert, talking about the ordinary everyday experience of menstruation and orgasm and other things that used to never be talked about. And the other thing I like about that documentary is that the second half of it is more extended interviews with women who had a problem that they've gotten over with some professional help. And so it sort of showcases the sort of situations where some therapeutic intervention might actually be quite helpful and useful. And that's quite a community education tool as well. Like, if you see yourself in this movie, maybe you can understand that something could be done about this. And the other fascinating thing about it, of course, is the woman who made it is not a clinical professional. She's an artist, and it's at least 10,000 times better than anything I ever got in medical school. So I don't know whether you got a list of pre-readings, but 100 Vaginas was definitely, it's a very good investment of 46 minutes of your time to have a look at that in SBS On Demand. Jasmine Abdul Qadir is a lovely gynecologist who works in Geneva and runs a clinic for women who've had female genital mutilation. And she has a fascinating TEDx talk, and her name is so unique you won't have any trouble finding it. And she, like me, she has designed a model clitoris as well because she found that she needed it for counselling and education in her clinic. There's also a Instagram art project and a book called Vulva Diversity, which is really educational material designed for young women to say, have a look at the variety and array of genitalia and understand that you do not need to surgically alter yours. I've talked about Betty Dodson's legacy. I haven't seen it because it's a subscription service. It costs $95 a month, but I understand that the old Kinsey Sex Research Institute in the United States has morphed into a online resource called OMG, and a very cheerful, vigorous gynecologist who does a lot of work out at the Lyell McEwen Hospital came bounding up to me after I'd been handing out clitoris models and said, oh, it's really good. It's like a textbook. I often refer patients to it, but it's got a lot of interviews with women about what kind of stimulation they enjoy and a lot of other stuff. And of course, family planning is a fabulous resource, and the family planning libraries, or in South Australia, we'd call that Shine, have got a lot of really useful stuff in them. And there's also the Labia Library, which is online photographic resource. But I think the main thing I really want to say to you is health literacy is not that hard to support it. And a lot of this education and problem solving is happening in the self-help zone, and you don't need to do anything about it. But if you decide to do something about it, don't have imposter syndrome and think that you know nothing. You do know a lot of things that actually could be very helpful to other people if you just unmute yourself. So that's sort of my closing message. And I hope that the workshop's giving you more tools to work with. And I think that's it. I think we should entertain questions, don't you? Maddie, would you like to chair and invite questions? And
yeah, absolutely. If anyone's got any questions, please pop them into the chat, and we'll give people a few minutes. But yeah, just in the meantime,
any in the chat?
Nothing as yet.
Oh, okay. Well, I'm happy to just put it out there and leave it at that.
So there's one that's just come through, Ia, asking for your thoughts on school education for women's anatomy.
Oh dear. Well, the South Australian Commissioner for Children and Youth has just put out a report. She consulted widely with school-aged children in South Australia about what sex education they had actually got and whether it was useful to them. And the situation is just abysmal. And, you know, Alan Tudge has been talking to the press recently about how he'd really like to cut everything useful out of the national curriculum. So I don't think things are going to get better. I've been shocked. When I ran tutorials for medical students about contraception and abortion and things, I used to say, well, who in the room got any useful sex education in high school? And like out of 14 or 15 people in a tutorial, medical students, who are like some of the most highly educated, smartest people in South Australia, one would put up their hand or two. Like it just, feminists have been calling for young women to have access to accurate factual information about themselves and their bodies and how things work since the days of Margaret Sanger. And it really hasn't cut through. And, you know, it's a political problem. It's about paternalism. And
yeah, it's interesting even seeing shows like Netflix shows like Sex Education, and that being, you know, people learning things from something like that they've never understood before either.
Well, I think the most common source of information for young people in South Australia at the moment is pornography, which is unfortunate because it's not all that factual, and it's never going to explain to you anything about consent or pleasure or lubrication or
no, absolutely. Yeah, no, absolutely. We can hope that it will get better over time. But yeah, I think that policy issue, and I think the individual school control is a really hard issue to overcome.
Yes. And, you know, if you went to a religious school, I mean, you only had to watch the Royal Commission into Child Abuse and Institutions playing out to understand the quality of governance in religious schools in Australia. You know, it's right. It's well understood, and yet people are still paying to have their children experience that. It's astonishing to me, but there you go.
All right. If there's not any more questions, we'll just... sorry.
I just want to say one thing, which is we're about to start doing some research. Rosalie Gribble at Flinders has found an advanced studies student who's going to spend the next 3 years looking into what is the base level of knowledge that starting medical students bring with them to medical school, so that they can understand more about what needs to be taught in the medical curriculum. So that's a response to the Child and Youth Commissioner's report.
Yeah, absolutely.
You know, there's a lot to be done, and a lot of women turn to their GP for education or their gynecologist. So I really want you to be well informed so that you'll have something to say when somebody asks you. That's why I'm here.
And hopefully with everyone's models, they'll find that passive education that lots of people have found, just having them clitoris models around their houses, and people, you know, ask what's that, or then it just opens up those conversations.
It leads to some very helpful conversations, and I've had some very interesting feedback from people who work with very vulnerable young women in detention and places like that, particularly ones that, I mean, women don't always tell you what they've survived, so you don't always know if the person you're talking to has experienced female genital mutilation or child sexual abuse or some awful traumatic event. But just talking in a constructive, factual and positive way about sexual anatomy and sexuality and sex is very helpful to those people.
Absolutely.
Yes.
Great. Well, thank you so much again, Lilian and Ia, for providing this experience this afternoon. I really hope that everyone's found it useful, and anyone that wasn't able to actually physically complete the workshop today will get the recording, and so then they can do it in their own time afterwards.
Right. Well,
we're excited to see. Yeah, excited to see where it goes. So thank you again.
Cheerio then.